Hello and welcome to another Emergency Medical Minute Presents. I'm Jeffrey Olson, fourth year medical student at the University of Colorado, and today we're going to be recapping our most recent event, Tox Talk 2025, which was an event all about toxicological emergencies. Today in studio, I have Dr. Preeya Prakash, and I'm going to let her introduce herself.
Hi, good afternoon. My name is Preeya Prakash. I am a general cardiologist here in Denver, Colorado. I've been practicing now for I'm in my second year as a general cardiologist. Before this, I did my training at Wayne State University in Detroit, Michigan. So I'm really happy to be here.
Great. We're really happy to have you here today. All right, let's jump into this really quick here. Our presenters presented on different toxins and what overdoses looked like. The first one we're going to go over is Digoxin. So we'll listen to a few clips from that soon, but before we get started, can you give us just a super basic understanding of how Digoxin works?
Sure. Digoxin works to increase your myocardial contractility, helps to both increase both stroke volume and blood pressure. It decreases your heart rate and increases your overall time of actual myocardial contraction. So going back to those specifics with the cardiac cycle, it's prolonging phase 3, shortening phase 2, so it helps to shorten that overall QTC interval. It increases the slope of phase 4, so it increases the automaticity of your atrial, junctional, and ventricular tissue, and it helps to slow phase 0, so it reduces your actual conduction velocity. So Digoxin actually mainly works at the sodium-potassium ATPase pump. So that pump is responsible for moving potassium ions into the cells, pumps sodium ions out. So it's maintaining a low intracellular sodium concentration and a high intracellular potassium concentration. So Digoxin actually works to inhibit that pump. So when that happens throughout the body, less potassium moves into the cells. That leads to an increase in potassium concentration in the bloodstream. That indirectly leads to an increase in intracellular myocardial calcium, so basically calcium that's in the myocardium or into those cells, and it increases cardiac contractility. So Digoxin also causes an increase in your vagal tone, so it reduces activity in the sinus node and prolongs conduction in the AV node.
Okay, so it seems like on a very basic level, we are trying to stop that sodium-potassium pump.
Exactly.
And then calcium's building up inside the cell?
So not only, like I said, do you have a high extracellular potassium concentration, but your intracellular calcium, like you said, increases when you inhibit that pump. And so then you're actually leading to increased contractility, and then it also it leads to the increase of tachyarrhythmias as well.
Okay. Now, looking back at the history of this drug, it looks like it has a really interesting history that for like centuries, it was like the heart failure drug. Kind of more recent history, 2010s, Digoxin was still commonly prescribed for heart failure. 2015, there were still over 1 million Americans on Digoxin. 2021, that number had fallen to 394,000. So still a considerable number, but declining very quickly. Why might a patient still be on Digoxin, and why are we moving away from it?
Yeah, absolutely. So, I think a huge reason as to why Digoxin is not used very regularly as part of guideline-directed medical therapy is because we've had such huge strides in those pillars of heart failure that we kind of use. And obviously I could go on and on about the medications that we use for heart failure. But now that we kind of have clinical trials and clinical evidence to support that those are the medications that help with morbidity and mortality, so beta blockers, ACE, ARB, ARNIs, mineralocorticoid receptor antagonists, those are kind of those main pillars. So because those kind of came into play, that's why Digoxin kind of stepped back as one of those main guideline-directed medical therapies. It's kind of rare nowadays to be starting a patient on Digoxin. A lot of the reason can be because it's, you have to continuously monitor levels a lot with certain patient populations, and there's a pretty high chance of drug-drug interactions. So the main cardiac comorbidities that we actually use Digoxin for is ventricular rate control in atrial fibrillation, and it can be used as an adjunctive drug, not part of those 4 pillars of guideline-directed medical therapy or main therapy for heart failure with reduced ejection fraction. But you can add it, especially if they continue to have symptoms, on maximally tolerated GDMT. There's main therapeutic concentration of Digoxin is usually it's cited in a lot of literature as 0.5 to 2 nanograms per milliliter. But actually, the newer heart failure guidelines nowadays are recommended to keep those concentrations lower, probably 0.5 to 0.9. And that's to actually help reduce toxicity risk. And toxicity risk actually does increase as levels rise above 2 nanograms per milliliter. And actually, clinical symptoms themselves can present at that level as well.
Okay, so to kind of summarize, it seems like probably never starting somebody on it as a first line, but adding it on for like difficult to control AFib or just heart failure that is kind of failing those first drugs. Okay.
Yeah, absolutely.
Okay, great. So thank you for that comprehensive look at digoxin. Let's get into our clip. This is Adam Greenhaw. He's a PharmD who works out of Swedish, and he brought this case and presented it. Let's listen to it now.
So a 20-year-old male was brought to the emergency department by his mother after intentional ingestion of an unknown quantity of his grandmother's heart medications. This ingestion was 45 minutes prior to arrival, and they brought the prescription bottles with her. The patient vomited 2 times prior to presentation. So luckily the mother brought some the prescription bottles. So anytime a patient presents with prescription bottles in an acute intoxication, we want to go through all of those, see what the quantity prescribed was, what day it was filled, how much remaining, and that gives us an idea of what the patient could potentially ingest. And you want to make the assumption, until it's ruled out, that they did ingest these pills that were missing. So just looking through all these, digoxin really is the main offender. There are 50 pills missing of 0.25 milligram tablets. So this comes to potentially a 12.5 milligram ingestion of digoxin. What are some early interventions we could do with a patient that just a toxic dose of digoxin before presenting? Well, exactly. So he said gastric lavage. So decontamination is what we'd be thinking of first, because that could reduce our half-life, reduce the amount that's absorbed, and really reduce the overall toxic effect. So historically, we've done forced emesis, gastric lavage, whole bowel irrigation, and activated charcoal. Traditionally, typically, the first 3 are not recommended, but activated charcoal is an intervention for decontamination that's mentioned by expert consensus. Activated charcoal, it's ingested orally, it binds to the drug physically, and it's eliminated in the feces, and it's not able to be absorbed. This has a strong endorsement of effectiveness from the 2024 expert consensus on digoxin toxicity. We can actually reduce the half-life of digoxin with the amount absorbed by up to 50%. And they're just case studies. There aren't like a lot of case series of digoxin. It's kind of hard to study, but in some studies it's reduced the half-life by 50%. Multi-dose activated charcoal is also effective due to enterohepatic recirculation. If you don't know what enterohepatic recirculation is, so essentially the drug was absorbed, went to the liver, and eliminated in the bile, back into the GI tract. And what does it do in the GI tract? Well, a certain percentage will get reabsorbed. So you kind of have this cycle of absorption going on, and you can really interrupt that by giving multi-dose activated charcoal. So activated charcoal, really our major contraindication is if the patient is vomiting or is at risk of vomiting. So this is kind of a rock and a hard place with digoxin, because the acute presentation, the initial symptoms are mostly going to be gastrointestinal, nausea and vomiting. So as we know, our patient vomited twice before presenting, and digoxin, they may not be vomiting when they come in, but there's still a risk of that effect occurring. And if you give them activated charcoal, you complicate your case if they vomit and aspirate that. Always assess the risk of vomiting before you give them activated charcoal. So expert recommendations say it's reasonable if the presentation is within 2 hours. That's when it still can be absorbed by the activated charcoal. And it's strongly recommended if the patient presents to a facility that does not have access to digoxin antidote. There's some, in lower resource areas, there's not as good access to Digifab or to antidote. In these cases, activated charcoal is one of the only few ways where we can reduce the absorption and reduce that load. So back to our patient case, this is 1 hour post-ingestion. Our patient has a heart rate of 75, blood pressure of 118/80, respiratory rate of 16, and a temperature of 98.5. So the provider decides to order a BNP, a CBC, an acetaminophen level, an aspirin level, a digoxin level, and an ethanol level. Establish IV access, cycle vitals every 15 minutes to monitor for deterioration, serial ECGs, and also consult toxicology. And the phone number 1-800-222-1222 works anywhere. We'll connect you with the Poison Center, whether you're in Massachusetts or Colorado. The provider also just good supportive care administers a liter of LR. So when we talk about a toxic ingestion, we want to know about the pharmacokinetics. That can paint us a picture of exactly what the drug's going to do and when it's going to do it and when it's going to be eliminated. It tells us when our peak effect is, it tells us how long it's going to last, it tells us how the body's going to eliminate it, and how different complications can prevent elimination and prolong the half-life. So digoxin has a bioavailability of 60 to 80%. With tablets, it's 80%. There are different formulations, but we would most likely see tablets. So a bioavailability of 80%. And it reaches steady state after 6 hours after ingestion. So our patient's still 1 hour out, and we're drawing a level. So just know if you draw a digoxin level within the 6 hours, it could be falsely elevated. It most likely will be falsely elevated. Kind of like if you're more familiar with acetaminophen toxicity, this is why your provider will order a 4-hour level along with their initial one. Initial one kind of rule it out to see if it's an actual ingestion. The second one is really objective. That correlates with the actual amount that's circulating. If you try to treat based off a level during the first 6 hours before it distributes, you might end up over-treating the patient. So when I talk about steady state, if you don't understand what that means, when a drug's absorbed, when a drug is administered at time 0, it's going to be absorbed, hit a peak level, and then it will start to distribute to all the tissues. And during that distribution, it's an extremely rapid exponential elimination. So if you draw during this, you're going to get a falsely high level. It's still useful to get, so you can confirm if the patient has legitimate ingestion. And the volume of distribution, speaking of distribution, for digoxin is large. Digoxin has a extremely variable half-life. 20 to 50 hours, can be extremely long in renal failure because it's 70% eliminated renally. A lot of different things can factor into this. Drug interactions can prolong the half-life. P-glycoprotein is a channel that pumps drug in and out of cells, and those cells including in the kidney and in the gallbladder. If you're blocking P-glycoprotein, they can't transport digoxin correctly, and it's going to prolong real half-life. Example, one of these drugs is amiodarone, which this great is on the list of medications his grandmother had. So if you had taken both of those, it could prolong the half-life. So 2 hours post-ingestion, the nurse recognizes a rhythm change on telemetry, alerts the provider, and repeats EKG and vitals. Here's our new vitals, significantly changed. Heart rate is now 52, blood pressure stopped at 86/40, respiratory rate is 20, and our SpO2 is 95%. What do you guys think of this EKG? Does anything jump out?
All right, we'll jump back in here. Dr. Prakash, I will offer it to you. One of everyone's favorite things about digoxin is its EKG findings. What are the EKG findings of digoxin toxicity, or if you want to break it down?
Yeah, absolutely. So, interestingly enough, and this was something that I kind of learned throughout my training as well, we kind of have those buzzwords that we learned during medical school about dig toxicity and EKGs, but it's interesting that there's actually some main EKG findings that can be seen with any use of digoxin and not necessarily due to toxicity. And this is a phenomenon called the digitalis effect or digoxin effect. So the digitalis effect actually is that distinctive scoped appearance of the STT complex, and you get shortening of the QT interval. So this is called what we all kind of know as the Salvador Dali effect, and this is because of the shape of his characteristic mustache. You also get flattened, inverted, and biphasic T waves in this pattern as well. So with this digitalis effect, you can also see mild PR prolongation. You can actually see U waves as well, which is a highlight of delayed repolarization of the ventricular myocardium. You can see peaking of the terminal T waves, and you can get some J-point depression. So all of these factors, especially with J-point depression, can correlate with abbreviation of the ventricular action potential, which is one of the effects of digoxin. And the digitalis effects, interestingly enough, and this is something that I think cardiologists kind of keep an eye out for when we're doing any sort of ischemic workup, digitalis effects can be accentuated by increased heart rate during exertion. So, when you're stressing someone, so for example, if you're putting them on a treadmill EKG test, you actually can then get false positive results with stress testing because you get kind of a worsening or an enhancement of these ST complex coving, and that can be a sign of ischemia as well. So it's something to kind of keep in mind if you're going to be doing ischemic testing on these patients. Like I had mentioned already, these can occur with both therapeutic and toxic doses of the drug. So you shouldn't necessarily look at the digitalis effect as a marker for toxicity alone. However, when you start to get the presence of dysrhythmia, that can indicate toxicity 100%. So these specific dysrhythmias include supraventricular tachycardia due to increased automaticity, and also a slow ventricular response due to decreased AV conduction. So for example, you can get frequent PVCs. specifically trigeminy, ventricular trigeminy and bigeminy, sinus bradycardia, but also the presence of AV block, anywhere between first degree AV block all the way up to complete heart block. One of the things that you tend to see classically with EKGs that are presenting with digoxin toxicity is slow atrial fibrillation. So this is something that, you'll see quite frequently where you'll get, QRS complexes pretty extensively dispersed throughout the EKG, but then you see that classic kind of sawtooth or kind of irregular pattern all the way through representing the atrial fibrillation. But specifically, you can have this phenomenon called regularized atrial fibrillation. So you get your slow atrial fibrillation, but you'll also have concurrent complete heart block, and then you also have a junctional or a ventricular escape rhythm on this EKG. And this is something that can be a pretty common phenomenon that you see with digoxin toxicity. So one of the things that we kind of get quizzed on quite a bit as cardiologists, especially when we go through board exams and things like that, is this pretty classic phenomenon also of bidirectional VT. So you actually get bidirectional or two different polarizations of your ventricular complex, and this is something that can be very classic for digoxin toxicity. Another thing you'll also see is polymorphic VT. So these dysrhythmias, along with the presence of digitalis effect, can really be a huge marker for digoxin toxicity.
Wow. Really good answer there. Okay, so back to the case. Heart rate for this patient is now 52. Mm-hmm. Is there any utility to using atropine for this bradycardia? Or should we think about the bradycardia different than like other bradycardia?
Right. Atropine can be in certain cases useful because it can block that increase in vagal tone on both the SA and AV node that's caused by digoxin. And that can actually be the first kind of marker that leads to bradycardia in a lot of these cases. However, there's always a caveat with using atropine as like your sole treatment measure, because depending on the level and intensity of your digoxin toxicity, it may not be enough to help overcome the sequelae that happens with dig toxicity. And patients actually may require temporary pacing or other kind of hemodynamic support as further treatment is provided.
Okay. And now we're cutting out a little bit of Dr. Greenhaw's talk here, but at one point the potassium did come back and it was high for this patient. I think that makes sense, kind of knowing how digoxin works, and it could have also been high from some other cause. Sure. But kind of regardless, should we use calcium to treat the hyperkalemia in the setting of a presumed digoxin overdose?
Right. There's a very intricate relationship between digoxin, potassium, and calcium. So as I mentioned before, DIG targets the NAK ATPase pump, inhibits its function, leads to high extracellular K and hyperkalemia. So that's likely, like you said, big marker of what caused the hyperkalemia in this patient. But with DIG toxicity, this action is further potentiated and it causes worsening hyperkalemia. And as we also talked about previously, intracellular calcium increases with the inhibition of the NAK ATPase pump, and that leads to increased contractility and the risk of tachyarrhythmias. Therefore, if you use calcium to help treat hyperkalemia in these cases, it could actually worsen the risk of tachyarrhythmias, and you probably don't want to use it in the setting of treating hyper-K in the setting of digoxin toxicity. So usually actually using Digifab or Digibind, which I'm sure we'll go into in a bit, should help to resolve the hyperkalemia itself. If the patient has severe hypokalemia, now going to the other side of things, in the setting of digoxin toxicity, it's important for you to focus on correcting the serum potassium in those cases. But specifically talking about using calcium to correct the hyperkalemia, that's not warranted in this case.
Okay, one final question here, and then we'll let Dr. Greenhaw explain Digifab with the rest of his talk. But just if/when should we be getting a cardiologist involved in a patient with digoxin overdose?
Yeah, absolutely. So, when your patient arrives to the ER, you're going to initially triage the patient. You're going to be kind of getting vitals, getting a clinical picture of what's going on. So at that point, if the patient's hemodynamic stability and clinical symptoms that I'm going to mention below are in question, then that should prompt an urgent evaluation and discussion with cardiology. So some of the main symptoms that we know come with digoxin toxicity, it's a whole multitude of symptoms, but specifically, from a GI perspective, patients present with nausea, anorexia, diarrhea can be a symptom as well. Vision-wise, they can present with blurred vision, yellow-green discoloration, and kind of halos around their eyes. Actually, the one patient I had that I did have to give Digibind to during my first year of fellowship, they actually the biggest symptom they had was that they were extensively fatigued and that everything in the room looked yellow. And so it was almost like that buzzword when we heard that. We were like, oh, we should probably look into this a little further. From a cardiovascular perspective, palpitations, dizziness, syncope, you may actually see a little bit more of that long-standing or progressive dizziness with patients who are on chronic DIG, but these are definitely symptoms that can happen that can prompt this kind of further evaluation. And then from a CNS perspective, confusion, fatigue, delirium, any sort of altered mentation should kind of prompt an urgent evaluation and, picking up that phone and saying, hey, I have this patient that's on DIG, or, potentially you're concerned that there might have been an acute overdose. This is what I'm seeing. What do you think we should be doing next? In terms of those EKG changes that I talked about, including signs of ventricular arrhythmia, you definitely want to be contacting cardiology at this point for further management. So in extreme cases, which I'm sure Dr. Greenhaw is going to be talking about as well, digoxin, immune fab, or it's also known as Digibind or Digifab, it's used as an antidote for severe toxicity. So it's recommended in these cases when any of the following is present. And interestingly enough, if the DIG level is still normal when you get it back, you would still treat them if you still have these symptoms. So hemodynamically unstable arrhythmia, end organ damage. If your DIG level is greater than 4 nanograms per milliliter in chronic DIG patients, if the DIG level is greater than 10, if there's an acute ingestion, and then also if your potassium levels are greater than 5 and if they're symptomatic from that standpoint. These are kind of the clinical symptoms and then those EKG findings that you really want to be alerting cardiology for right away.
All right, awesome. Let's go on to clip number 2. We'll listen to it now.
So, on to our antidote, digoxin-specific antibody fragments, also called DSFAB. Many names: digoxin immune fab, Digibind, Digifab. Just because all these are tongue twisters, I'm just going to call it Digifab for the rest of the presentation. So Digifab is administered intravenously. Antibodies bind and neutralize digoxin. It's the definitive treatment of digoxin toxicity. It has a very good clinical response rate of 80 to 90%, and arrhythmias typically respond within 30 to 45 minutes. Adverse events that can occur: a potassium reduction, which is pretty common. You're kicking those pumps back online, but that potassium is going to go inside the cell. It could drop the potassium, so you want to continue monitoring their potassium. Fun fact: when you give insulin to patients to shift their potassium, sodium potassium ATPase is what it's working on, the insulin itself. So kind of intuitive. Rare reactions: anaphylaxis and hypersensitivity reactions, but those are rare and you would treat them as you normally would. So Digifab, there's a couple different ways to dose it. Traditional dosing, if you look at the package insert, says for acute toxicity, administer 10 to 20 vials to the patient, assess for improvement, administer the second set of vials, and it's dosed in vials, by the way, if the patient does not improve or if they deteriorate again. So Digifab, I called my technician, or the technician that works at our hospital that does our purchasing. She says each Digifab vial is $4,700. So that's near $100,000 if you're doing 20 vials. There's other ways to administer it. If you know the digoxin concentration, you can do a calculation to determine how much based off their body weight and the DIG concentration. Again, that 6-hour interval becomes more important here because you could be overdosing if your level is pre-distribution. But anyway, you dose based off of digoxin concentration and patient weight. So our patient, based off that dosing, will get about 7 vials. Another way is based off the amount ingested, still about 7 vials for this guy. There is a more modern way of dosing, or another recommendation for dosing digoxin that's more cost effective, and that is to give 1 or 2 vials to the patient, assess for improvement, and if they deteriorate again, give a further dose, vial or 2. And this was done in some patients, and the patients they had in a patient case, they had a DIG level of about 12. Their calculations said to give 8 vials. They gave their patient 2 vials. They responded. They didn't have any other complications. So they saved about $40,000 just from giving smaller doses.
All right, we'll move on to our second presenter, Dr. Travis Barlock, a very familiar voice on the pod. He presented, and I will spoil it now, it is a beta blocker overdose. And before we even listen to it, can we just get a really brief kind of synopsis of the different beta blockers, maybe focusing on like kind of what makes each one different and special?
I'll be as brief as possible. Beta blockers are primarily split into two categories. So you have your selective and your non-selective beta blockers. Selective beta blockers specifically are selective for the beta 1 receptor. So it's that major pathway for the sympathetic response in the cardiovascular and renal system, so your flight or fight response, and it causes increased heart rate and contractility. So specifically the words that we like to use are chronotropy and inotropy. And specifically in the renal system, the stimulation of renin for the RAS pathway. So your specific selective beta blockers are atenolol, bisoprolol, metoprolol, and esmolol. So we, in the cardiology field, you hear these agents being called cardioselective. Non-selective beta blockers bind to both your beta 1 and your beta 2 receptors. Beta 2 receptors act in the smooth muscle, primarily in both the bronchial and the vascular systems, and your stimulation of these receptors leads to bronchodilation, vasodilation, and it can actually stimulate gluconeogenesis and glycogenolysis. I'm actually going all the way back to the Krebs cycle for this one. Non-selective beta blockers are carvedilol, labetalol, and propranolol. So sotalol is also a beta blocker, but it usually falls under your category of a class 3 antiarrhythmic, and that's due to its associated properties. So we're not really going to focus on that. Some beta blockers can actually have mild additional alpha-1 blocking capabilities, and that helps to decrease heart rate and blood pressure. So carvedilol and labetalol also have a little bit of that alpha-1 blocking capability. So therefore, if you look at it, by blocking these beta pathways, your chronotropic and inotropic effects on the heart are inhibited, and the heart rate slows down as a result. Beta blockers also decrease blood pressure via several mechanisms, including the decreased renin and reduced cardiac output. The negative chronotropic and inotropic effects lead to decreased oxygen demand. So this is actually how angina improves after beta blocker usage. These medications also help to prolong your atrial refractory periods, and that's why they can have an antiarrhythmic effect as well.
Okay, so now with that background information, we will jump into Dr. Barlock's talk.
Travis Barlock, and this is going to be a case on an overdose. It's night shift, and we get a call from EMS. They tell us that there is a 14-year-old female who was found unresponsive by her mom. What we know is that she was drinking at some party tonight. Don't know too much else, but they do report that they find empty pill bottles scattered around the patient. The paramedics provide her with a nasal pharyngeal airway. They do note that she was throwing up after that. And then they tell us that they can feel a pulse. Heart rate's about 62 beats a minute, but they're unable to actually auscultate a blood pressure. She's satting in the mid-90s, and her glucose is 140. The medication bottles that they report are the ones that are listed here. We have propranolol, ondansetron, naproxen, and famotidine, with the dosing and number of tablets that are prescribed listed, and all of the bottles were empty.
So we'll jump back in here. If you are worried about a propranolol overdose, what medications do you want on hand to help you treat that?
Alrighty. Well, most of your beta blockers are moderately lipophilic. Certain beta blockers have extensive lipophilicity, and they actually have a large volume of distribution. So propranolol is the most lipophilic beta blocker. So it can easily cross your lipid cell and the blood-brain barrier and can actually cause seizures in overdose cases. Hypoglycemia and altered mentation are the two most common presenting symptoms with beta blocker overdose, besides your overarching bradycardia as well. Biggest thing is you want to evaluate the airway, given that patients can be altered and so obviously potentially not protecting their airway. Interestingly enough, atropine can actually help in these situations, not only to help combat the bradycardia, but also if you're thinking about, intubating and manipulating the airway, this itself can cause vagal stimulation and precipitate bradycardia. So having atropine on standby or actually giving atropine during the intubation process can actually be beneficial in these cases. Patients also can have bronchospasm due to overdose, since we mentioned the pathway kind of above. So supplemental oxygen and bronchodilators like albuterol should also be considered in these cases. So if patients are actively seizing or seizures have occurred in this process, benzodiazepine should be used first line. Obviously, throughout this entire process, lab work should be obtained simultaneously as well as an EKG to evaluate the nature of bradycardia and if there's any evidence of QRS widening and QT prolongation, because this could obviously herald the onset of ventricular arrhythmias as well. So if you do see presence of QRS widening and QT prolongation, sodium bicarbonate mag sulfate can be beneficial in these cases as well. The primarily known antidote and the one that's kind of common within literature for beta blocker overdose is glucagon. Even though, surprisingly, and I kind of looked through this as well prior to our talk today, is that there's no actually controlled trials in helping to prove the efficacy of glucagon. It's especially useful in beta blocker-induced cardiotoxicity, and the interesting way it works is that glucagon bypasses the beta pathways, and instead it actually stimulates directly the cardiac glucagon pathways that create adenyl cyclase, which increases your intracellular cyclic AMP, and that's independent of your beta pathway. That leads to calcium influx and stimulation of the heart rate and contractility. One of the possible side effects, though, of glucagon can include hypocalcemia and hyperglycemia. Hypocalcemia should be treated in these patients. If patients then become, throughout your entire process, triage and clinical evaluation of this patient, if they're refractory to atropine and glucagon, there's a specific treatment called high-dose insulin euglycemia, or the HIGH treatment. Could be something to consider. This is something that we tend to see a lot more in calcium channel blocker overdoses, but it can be used in these cases. So high-dose insulin and euglycemia is a pretty safe and simple way to augment cardiac contractility. So to keep this kind of short, insulin increases your glucose and lactate uptake into the myocardium. It helps to improve function without increasing actual myocardial demand. It also helps to promote contractility by increasing your sarcoplasmic reticulum calcium ATPase activity, and then also your cytoplasmic calcium concentration, increasing contractility that way. But it doesn't actually improve chronotropy, which can then cause associated vasodilation. So that's something to kind of think about if you're using this pathway. This pathway itself can also cause profound hypokalemia and hypoglycemia. That can actually worsen the cardiotoxicity in the setting of beta blocker overdose, so you want to really monitor these patients closely. Make sure you're getting frequent lab work done so you're stemming the possibility of this being the case. Now, usually if the overdose is profound and causes hemodynamic instability, glucagon or the agents that we just talked about should not be used as your sole agent of management. So nothing you're doing is kind of happening as a standalone. You're kind of doing things pretty consistently and pretty much overlapping a lot of your treatment. Cardiac pacing, either transvenous or transcutaneous, should be used as a temporizing measurement in these patients to help promote hemodynamic stability. And actually, the discussion about initiating ECMO or mechanical circulatory support should definitely be considered, because with beta blocker overdose, a lot of these patients, what the most serious complication can be is that these patients can develop cardiogenic shock. So this is definitely something you want to consider in these cases. Pressors, starting with potentially norepinephrine, should be considered simultaneously depending on hemodynamics and instability. Sometimes the vasopressor choice can be dependent on what your clinical findings are for the patient. Other inotropic agents like milrinone, which helps to increase cyclic AMP in the system, can actually be beneficial in increasing inotropy as well in these cases. One interesting thing from an outpatient perspective is that to avoid acute toxicity situations, you can actually potentially use extended release formulations for your patients as an outpatient. And that can be more of a preventive strategy, because by using the longer acting formulations, this can delay peak toxicity versus using the short acting agents. So this is something to kind of consider if you've had a patient that potentially develops beta blocker overdose because of, unfortunately, if they're elderly and they have extra doses or something of that nature. This is something that you can kind of consider as an outpatient if they still need to be on a beta blocker.
All right. So I kind of know what's coming, and we're going to see how Dr. Barlock's management compares to that. I think as we listen in, you're going to hear a lot of those similar drugs and therapies brought up. So let's go into that clip now and see how Dr. Barlock handled this.
The patient arrives, so heart rate's now 51, blood pressure 71/37, breathing 24 times a minute, satting 84%, and temperature about 35, about 56 kilos. The patient was a GCS of 4, has 3 millimeter pupils that are equal, round, and reactive to light. Distant heart sounds, weak, thready pulses. There is emesis noted around the mouth, and skin is markedly diaphoretic. Now, we have a differential. So all we know was found down, unresponsive, looks really bad, pills empty, what could be going on? So I kind of think of differentials in terms of critical, do not miss, bad, and then kind of not a big deal. Does anyone just shout out maybe some of the critical bad diagnoses we can't miss in this patient? Beta blocker overdose, for sure, right? She's got propranolol listed. It's an empty bottle. She's bradycardic, hypotensive, GCS of 4. Critical diagnosis cannot miss. Absolutely. Is there an intracranial hemorrhage? We don't know. She could be bleeding into her brain. Absolutely. Anything else? Septic could just be in some shock state, just generally speaking. The patient also, could have maybe had some cardiac arrest, and could be in some strange tachydysrhythmia or bradydysrhythmia rather. So immediate interventions. You already mentioned airway involvement. We are going to need to take this patient's airway. And we know that once we push an induction agent as well as push a paralytic, that's going to drop their blood pressure even more. And then we start putting an endotracheal tube in and start putting pressure on the lungs. We're going to decrease our venous return, and that'll further decrease our blood pressure. And this patient already has low heart rate, low blood pressure. So what do we actually do first? Our kind of mantra in emergency medicine is the ABCs, right? Airway, breathing, circulation. But in this patient, is that really what's the path we should take, or is it more maybe CAB, circulation, airway, breathing? It's actually a really tricky kind of thing to navigate. In reality, it's probably trying to do them both simultaneously, but in my opinion, in this patient, with a heart rate of 51 and a blood pressure of 71, you could kill the patient by securing the airway without optimizing that. What we did was try to optimize the hemodynamics. So started off with epinephrine. We started actually off with push dose epinephrine. Just it's difficult to get an epi drip going right away. So we can get epinephrine. We can dilute it and then push it in these aliquots every minute or so, which is basically functioning like a drip. Bagging in the meantime. And then once that's optimized at least enough, now let's intubate the patient, secure the airway. So that's what happened. Medications to use for intubating. There's different options for our induction agents as well as our paralytics. For this patient, we opted to use ketamine. Probably my go-to agent for most cases. But specifically in this case, I think it was very important to use ketamine, mainly because of its hemodynamic support and its effects on, and the fact that it is at least somewhat adrenergic. So airway secured. Now it's time to kind of reset, and let's kind of just see now how our other organ systems are doing. The first thing I wanted to do was to look at the patient's heart. And so by doing a bedside ultrasound, it was a globally diminished ejection fraction. So now when thinking of our differentials, what's going on, the pieces are starting to come together, and we are really now very, very suspicious, very concerned for a beta blocker overdose. This is all happening. We still have diagnostics to pursue as well as therapeutics. So there's labs, there's imaging, and treatments.
All right, we'll jump in again here. So let's talk echoes for a minute. What single cardiac view do you think gives you the most information for different scenarios and different questions you're asking about what's going on with a patient?
Yeah, it's as a cardiologist, it's a little tough to say there's like one specific view that like will give you all answers you need. But in a pinch, and especially in these, critical scenarios, I would say apical 4-chamber and 5-chamber can usually give you the most information for both atrial function, ventricular function, and evaluating the valves. Usually, if you want to comment specifically on wall motion abnormalities, you want to get multiple apical views and get a thorough view of the myocardium to be able to completely rule out wall motion. So, off of your basic snapshot of 4 or 5-chamber, you're not going to be able to say 100% that there's no wall motion abnormalities. However, if you're unable to get a good apical view to look at specifically the ejection fraction and overall function, a subcostal view can actually be helpful to obtain a good 4-chamber view. And this is a good way for you to be able to quickly evaluate the ejection fraction when the patient's, in triage and you're kind of trying to figure out what's going on.
Okay, great. Thank you for that. Let's play the next part of Dr. Barlock's talk here, and then I'll have a few more questions for you.
Does anyone want to think of some labs that we might get on this patient? Okay, you're in drug screen for tox? I agree. We did that. Perfect. Okay. Dr. Lynch. Excellent. Basic labs. Love it. Okay. And ingestion labs, like maybe Tylenol and an aspirin level. That's exactly right. And that is what we did. So we also got a venous blood gas. So venous blood gas, CBC, BMP, urine tox screen, aspirin, and Tylenol levels. You guys are phenomenal. All right. Any imaging studies? You guys want to get any imaging on this patient at all? CT of the head. Excellent. Okay, perfect. So that's what I did. Got those same things. We got, and I included EKG on this as well. But EKG, we already did the ultrasound of the heart, and then doing a chest X-ray and a CT of the head. Now, what this talk is really about are about the treatments. So, what treatments do we initiate? Now, I know we've got some experts in this field, and so I'm going to try to avoid them. But does anyone want to shout out any of the possible options for treatments here? Glucagon, excellent. Glucagon is one of the meds that we provided. High dose insulin, excellent. I like that you said high dose, right? That is correct. It's not just insulin, it's high dose insulin. That's right. Intralipid, love it. So lipid sink, a fatty emulsion. That's exactly right. We did that too. What we did were those meds, including a few others that were already mentioned maybe, but we're giving epinephrine, giving glucagon, atropine, also calcium, and then as listed, high dose insulin and intralipid. Here's the EKG that we got on this patient. Kind of confusing, but we can deconfuse it a bit. So the first thing I'd say is it's narrow and it's overall regular, although we see a couple extra beats there. So it's regular with a couple extra beats. It's narrow complex. And then is it sinus or not? I just check up in V1 and lead 2. Is there a biphasic P wave or an upright P wave? Not really. And so this would be a junctional rhythm. And then based on the rate, it's like around 75 or so. That means it's an accelerated junctional rhythm. And then these extra beats here, those are not PVCs because they're narrow and they don't really have this preceding P-wave component, and so it's actually a PJC. That's a premature junctional contraction. Otherwise, QT is kind of borderline, not crazy. ST segments are fine. So this is an accelerated junctional rhythm with PJCs. Next, the medications. So we gave all those meds that were mentioned before. Push dose epi was at 10 microgram aliquots. 3 grams of calcium gluconate, 5 milligrams of glucagon, 0.5 of atropine, and insulin at 56 units. So that's 1 unit per kilo. The patient's 56 kilos. So right as this is all happening, the patient now loses pulses. So look up on the monitor. We do see electrical activity. So this is by definition PEA, so pulseless electrical activity. Other thing that was important to do at this juncture was to look at the ventilator. It's easy to forget that we've just done a major intervention on the patient. We're now controlling their breathing. And so did we write main stem? Did we kink the tube? Did we cause a pneumothorax? Did we cause something like that, which could have caused an arrest? And so looking at the ventilator, anytime there's a code, is very important just to check that it's not something with the vent. Anyway, normal peak pressures was very reassuring. And then we could go and think, okay, now it's PEA from the normal cause. Now, obviously, it's start CPR. We start CPR. We give now not the 10 mic aliquots of epinephrine, but now we're doing cardiac dosing as well as getting the high dose insulin in. After just 1 round of CPR, the patient responded actually very well, had absolute return of spontaneous circulation and saw organized contractility on bedside ultrasound. And on the bottom, we have now markedly improved hemodynamics with a heart rate of 71 and blood pressure now 103/88. Sad and great. So the intralipid then was able to be administered. I know this patient is technically pediatric and is 56 kilos, and so it's 1.5 mLs per kg. But for all adult patients, I just kind of go easy button, just grab it's 100 mLs of intralipid and hang it. And that is how I usually think about it. So those are kind of the 100 cc's is just kind of the number to keep in your mind for most patients. This patient's now definably critically ill, getting multiple different medications, and it requires very intensive hemodynamic monitoring, and so absolutely deserves a central line and an arterial line, which were then placed. And here's now finally the chest x-ray. So this is pulmonary edema, and that also kind of fits with our clinical picture, right? This patient just had a beta blocker overdose, and now their heart is failing, and so all this blood is backing up, pushing on the lungs, exuding out, and making the lungs wet, and is probably why she was, hypoxic. Also, there could have been an aspiration event. That tends to be a little bit more delayed, but still possible. All right, so next, toxicology was consulted, pediatric ICU was consulted. Both came actually down to the bedside very quickly when discussing this case. And it was actually a really collaborative discussion trying to figure out what is actually the right trajectory for this patient. She was definitely improving, although technically coded on the table just moments before. And so the decision was made to not just admit her to the PICU that we had at the time, but instead to transfer her to a center with ECMO capability, just in case the patient deteriorated more as like a rescue therapy, which I thought was a thoughtful consideration. So patient was ultimately transferred to an ECMO center. Some of our labs came back. This is more just for completion's sake. There's only a couple things that are notable here. One, the drug screen is negative. And then looking at our blood gas here, there's really only two things that really stand out. Does anyone want to? Yeah, we have an acidosis. Okay, is it metabolic or respiratory? It is metabolic, 50-50 chance. Nice, right? And one way you can do that, like very easily, is to just at least, it's not totally comprehensive, but if you just look at the base deficit and see how big that is, that at least is the metabolic component of it. So a base deficit of 8 tells you there's at least 8 units that are contributing to the metabolic component of the acid-base imbalance. But yeah, so metabolic acidosis. Otherwise, important things on the labs, I would say it is notable that the patient was not markedly hyperkalemic, another thing that can cause bradycardia, and kidney functions normal, glucose again normal. So anyway, overall course, the patient was transferred on day 1. The next day, self-extubated, probably best case scenario. Echo was repeated, showed improvement in ejection fraction. Several days later, had an MRI completed just to make sure that the brain looked okay, totally normal, was walking around the unit. This is a patient that technically died 4 days before and is now walking around the PICU floor. Medically clear on day 5, then ultimately transferred to a psychiatric facility thereafter.
All right, we'll jump in one last time. So one therapy that didn't really get brought up that I had some questions about during this case is the idea of doing some form of temporary transcutaneous or intravenous pacing. Why may or may not this have been a good idea in this case, in other cases? Can you kind of give us your opinions on pacing?
Sure. Transcutaneous and transvenous pacing methods are both appropriate to use if the patient's hemodynamically unstable, and it can actually be used to kind of temporize or temporarily stable the patient while discussions are had regarding mechanical circulatory support. The reason why these methods are sometimes kept on standby, unless required for hemodynamic stability, is that you want to really try to preserve the underlying pacemaker capability of the patient and give it a chance to recover, especially if you are convinced that the pacemaker capability is diminished because of a reversible cause. So sometimes when you actually override a patient's native pacemaker, it can almost cause like a stunning effect and prevent full recovery of the native pacemaker. So pacing is really kept for those critically ill, hemodynamically unstable patients where you really need a temporary measure to be able to keep them stable, to keep their heart rate up and their cardiac output up. Otherwise, it's okay to give them some time, give them medical management if they're stable, and kind of see what your next steps would be.
Okay. And my last question for you before we listen to the rest of Dr. Barlock's clip here. Same question as the last case. If/when should we get a cardiologist involved in a patient with a propranolol overdose?
So I'll go back to my same answer too. Like in many cases, if there's evidence of hemodynamic instability and clinical decompensation on presentation, if you contact cardiology early on within triage and evaluation of this patient, it can be incredibly helpful in helping you formulate a plan and the next best steps for this patient. Especially if, this patient does have severe features of cardiogenic shock and you need to think about initiating mechanical circulatory support, ECMO, what your next steps might be from that standpoint. Getting cardiology involved early can really help to expedite the process and, hopefully doing the best that we can for this patient.
Okay, here is the rest of Dr. Barlock's talk.
I just was like reflecting on this case and thinking about it, and there's all these different steps that worked out very well. But in my mind, the thing that really made the difference was the heads up by EMS. The time that they gave us to ready the room really made all the difference and set everything up. And so it just can't be understated, the appreciation and the value that paramedics provide by giving us that notification. And so that's really, I think, what, like, they saved her, So this was a case of a beta blocker overdose, and thought it'd be cool to talk about a little bit. So beta receptors scattered throughout the body, kind of simple mnemonics, right? Beta 1, one heart, beta 2, two lungs. But it's also scattered on different tissues, your adipose tissue, your liver, causes increased renin secretion and in the kidneys. Now, there are also, you have your, just for completion, I guess, so your alpha receptors, which when they're bound on your blood vessels cause constriction, and there's also inhibitory receptors that are the alpha 2 that are agonized as well. So when you have a beta blocker overdose, you have the combo of bradycardia and hypotension, which already in and of itself is an interesting combo when seen in the emergency department, right? Because most of the time when you're hypotensive, you're tachycardic, right? And so that's your heart's response to the drop in blood pressure. So when you see low blood pressure and low heart rate, that's kind of just an odd combo. It makes you think of, maybe, is the heart primary? And there's only a couple things really that are in that differential already. And so beta blocker overdose, one of them, maybe thinking neurogenic shock, or maybe thyroid being low, things like that are things to consider. But with beta blocker overdose, in addition to those two, we can see dysrhythmias. If it's really bad, you can progress into having delirium, seizures, coma, beta 2 agonism of the lungs to cause dilation. If you block that, you get bronchoconstriction. It's the exact opposite. And then hypoglycemia, again, from liver production of glucose being blocked. Differential for that, other than the ones that we mentioned, more specifically to ingestions, are going to be calcium channel blockade, digoxin toxicity, clonidine, and even cholinergic toxidromes. And so the management, just simplifying it, is going to be ABCs, make the heart beat better, and clear the toxin. So as far as ABCs, I think of ketamine as our go-to agent for induction, and don't think there should be really any room for any other options there. And then using atropine and push dose epi to kind of, again, give you that extra hemodynamic support when intubating, just being mindful again of those blood pressure effects that we see when you do intubate. Promoting contractility. So all those meds that you guys were quick to suggest are the ones that we do. So glucagon, calcium, epinephrine, high dose insulin, and then even, it comes up again, look at that methylene blue as a last ditch effort, can be done. So high dose insulin was something I wanted to talk about just very briefly. If we look back at the receptors that the beta receptors are, kind of the tissues the beta receptors are scattered throughout, you're blocking cardiac output, you're decreasing renin release, you're going to decrease glucose production by the liver, and you are also decreasing lipolysis from the adipose tissue. And so beta blockers shift the heart's energy metabolism from a high reliance on fatty acids to a greater utilization of glucose. And that glucose is often also intracellular. By reducing free fatty acids in the bloodstream, beta blockers cause the heart to increase intracellular glucose uptake and usage, but it goes through it basically. When you're giving high dose insulin, you're actually really improving cardiac contractility by promoting glucose uptake and utilization. But I think of it like the myocardium is just so now deprived of glucose, and the cells know what they want to do. They've got a very specific function, right? It's when those cells are functioning properly, they're beating. And once they're starved intracellularly, and you finally give those cells a little bit of glucose, they finally contract with the way that they're supposed to. And so we actually see a very steady dose response curve. Basically, you give more insulin, they get more contractility. There was a study that was done that looked at giving 1, 5, and 10 units per kilo. This was done in pigs, but they saw a very proportional increase in cardiac output with increased dosing. One animal study of insulin used again in propranolol overdose was actually stopped early. It was again done in pigs, but they took one group and were giving them vasopressin and epinephrine, and the other group insulin and glucose. And vasopressin obviously works through a different set of channels. Epinephrine, you'd think maybe would bind the same receptors, maybe displace some of the beta blockers. And so there's a theoretical advantage to maybe going with these two. But the study was stopped early because every pig that died within 90 minutes that got that therapy, and everyone survived that got the insulin. So we have good reasons to think that the insulin is one of the most important treatments. I do put this out here just to really drill it into the minds of all of us, nursing, techs, and other providers, that the dosing is 10x your dosing for DKA. It's 1 unit per kilo and not 0.1 units per kilo, which is just really fascinating how much insulin you're actually giving these patients. And so just not be afraid of that dose. And I think we've even had to go through different calibrations of the pumps to like permit it, because there's been like overrides and stuff that have needed to be done. But it is obviously what they need. So lastly, just removal of the toxin. Intralipid acts like a lipid sink. It's like a fatty emulsion that circulates through the body, and propranolol in particular is very lipophilic, and so it will suck up some of the circulating propranolol and prevent it from binding more. Charcoal can be given if they're presenting very early, and also, as there's already been mentioned, if there's not aspiration risk. Hemodialysis can be considered, but a lot of these beta blockers aren't really renally cleared anyway, so it just depends on which beta blocker they're actually taking. And then lastly, ECMO, which was the reason why she ultimately was transferred out. So just a brief list of a couple of the lipophilic ones in your mind. So highly lipophilic are propranolol and carvedilol. Moderately so are going to be labetalol and metoprolol. So, all right. Well, thank you.
Thank you for listening to Emergency Medical Minute Presents. I've been Jeffrey Olson. Thank you to all of the contributors on this podcast, Dr. Adam Greenhaw, Dr. Travis Barlock, and Dr. Preeya Prakash. And a special thank you to all of the EMM members who made our event Tox Talk 2025 possible. Thank you all for listening. Have a good rest of your day.